and you can vote, is CVP dead? Who is for yes? 1, 2, 3, 4. Who is for no? OK, the majority. Good. So I have nothing to do. But to try to answer this question, I would like to go back to the past, if you want, just for a while. You know that CVP was well alive before the emergence of the pulmonary catheter. And for example, this is one of the articles I can download. I could download it because it was the other ones were not available. This is a classical paper looking at the classification of shock states. It was in 1971. At that time, the PA catheter was not popular, or it was just the beginning of the PA catheter, Swan-Ganz catheter. At that time, we used CVP to distinguish between hypovolemic shock, cardiogenic shock, and so on. It was very popular. But you know that CVP almost died in the 80s because of the emergence of the Swan-Ganz catheter. And maybe you don't remember, but at that time, in the 80s, in US only, 1.5 million PA catheter were inserted per year. It's not negligible. It is just one PA catheter per 170 citizens, not patients, American citizens. It is a lot. And after, CVP was revived in the beginning of the 2000s. Why? Because, of course, there was a decline in the PA catheter, and this is a study showing the decline in the use with time. And if we extrapolate to now, very small rate of insertion is still done. And why there was a decline? Because of some studies. For example, this one, the FACT trial, showing in a comparative study, PA catheter versus CV line in a randomized fashion, showing that PA catheter-guided therapy did not improve survival or organ function, but was associated with more complications than CVC-guided therapy. Another reason, of course, was the emergence of the early goal directed therapy using CVP. And you know, everybody knows the REVERSE study showing a reduction in mortality when compared to a control group. But you know that CVP was used in the EGDT protocol, and the values of 8 and 12 are very famous now, and this is why the previous surviving sepsis campaign guidelines recommend to target a CVP between 8 and 12. But you know that CVP, in fact, in the REVERSE study was in both arms. So CVP couldn't be responsible for the success of the EGDT in the REVERSE study. And now we also know that we have at least 3 randomized, multi-center, randomized clinical trials comparing EGDT and standard care and showing no benefit of EGDT over standard care. But another reason of the revival of the CVP is the field challenge revisited by Jean-Louis Vincent and Max Aiwai, and Jean-Louis participated in this revival by proposing a safety limit for field challenge of CVP of 15 meters of mercury. You can discuss the number. Nevertheless, CVP was pushed on in this paper. And this results in a large use of CVP as an indicator for fluid administration. And this is well illustrated by the Fenice study, a European study proposed by the SICM, and Maurizio Cecconi was the first author. And this study showed that when intensivists want to perform a field challenge, they base their prediction of fluid responsiveness mainly using CVP, which is the main variable when something is used. But in the majority of cases, nothing is used. And it is also the case in the operating room setting, where CVP is used a lot. And I would say there is a large use, but probably an abuse of CVP as an indicator for fluid administration. And you know this kind of article, this one from our group in Bicêtre Hospital in France, where we showed that CVP cannot distinguish between responders and non-responders of fluid administration before giving fluid. As you can observe, responders and non-responders have the same values of CVP before. And this was confirmed by many other studies. This is a meta-analysis by Paul Merrick and co-workers, looking at all the studies that addressed the issue of fluid responsiveness using CVP. And a lot of studies were included, 43 studies, and the number of patients was huge, 1,800 patients. And the summary area under the RO curve for the prediction of fluid responsiveness using CVP was only 0.56, which is very close to 0.50. This is like tossing a coin. And the reason is because CVP, even if it is a measure of preload, cannot predict fluid responsiveness. If we remember the physiology and the Frank-Starling curve, stroke volume and preload, we have not one single Frank-Starling curve. Of course, we have a family of curves between a normal heart and a failing heart. And therefore, it is impossible by just looking at one single value of preload, for example, CVP, to know if the patient is preload responsive or not. So static measures of preload, such as CVP, cannot reliably predict fluid responsiveness. So the question now is, should we still use CVP today? Clearly, no, for predicting fluid responsiveness. And this is confirmed by many statements and many consensus reports. This is one from the ESICM, also shown by Jean-Louis Vincent before. We recommend not to target any absolute value of ventricular filling pressure, like CVP or volume. But maybe we can use for helping to stop fluid administration as a safety limit. What happens in case of preload responsiveness? This is the cardiac output or venous return curve on the y-axis and CVP on the x-axis. If your patient is preload responsive and if you give fluid, you should increase mean systemic pressure. You know this upstream pressure for venous return. And if the patient is preload responsive, CVP increases, but just a little only. And the difference between mean systemic pressure and CVP should increase with fluid. While if your patient is preload unresponsive, the same increase in mean systemic pressure with volume infusion also results in a large increase in CVP. And at that level, you have no benefit in terms of cardiac output, of course, but in addition, there is a risk of increasing CVP at too high levels, and the risk of organ failure by venous congestion. And this is well illustrated in this study we did with Laurent Guérin and Xavier Monet, our unit, last year. And we estimated mean systemic pressure, and we measured CVP. In fluid responders, there was an increase in the gradient because CVP increased a little in comparison to mean systemic pressure. While in fluid non-responders, there was no difference between before and after fluid administration because CVP increased a lot. So CVP can be used as a safety limit when you already give fluid. Also, we can use it for assessing RV dysfunction and its response to therapies. But in this case, you need to take into account the transmural CVP, which is very important in case of applied PEEP or intrinsic PEEP. In this situation, you cannot rely on the measured CVP, but you should subtract something which comes from PEEP transmission. Also, you can say yes for assessing downstream pressure for organ perfusion, because don't forget that organ perfusion depends not only on mean arterial pressure, but also on the downstream pressure, and the downstream pressure is more or less reflected by CVP. So if you have an elevated CVP, you can think that you have an elevated downstream pressure for organ perfusion, and you you have to think about either to decrease CVP or to increase AMAP. It is another reason to target a higher AMAP in case of elevated CVP. And this is very helpful to try to choose the optimal AMAP target in shock states. But in this situation, you should take into account the measured CVP and not the transmural CVP, because the measured CVP is the back pressure for organ perfusion. Of course, we have many sources of errors of measurements with CVP. This is the main issue, I think. First, there is a problem with the anatomic level, 0 level. You know that you should place your transducer just 5 centimeters below the sternum angle. It's not so easy to identify the appropriate level. For example, in this study, the authors asked 50 physicians and nurses who were experienced with pressure measurements to place the transducer, external transducer, at the appropriate location in the same patient. In fact, they found a very huge difference between doctors and between nurses. And when the patient in the semi-recumbent position, 30 degrees head up, you can have a difference between operators of 40 centimeters. And 40 centimeters corresponds to 30 millimeters of mercury. So, in the same patient at the same time, a CVP value of 0 can be found by one doctor or nurse, and of 30 millimeters of mercury by another one. And this is a real problem. And you can imagine the consequences in terms of administration of fluid or diuretics. Another problem is the correct value should be measured at the foot of the C wave. It's not so simple. Do you do this? I think that nobody does. Maybe Jean-Louis, maybe. No. It doesn't matter. Also, but maybe this matters. CVP should be measured at end expiration. This matters. And normally, why end expiration? Because normally intrathoracic pressure, which should be subtracted, is close to 0 at end expiration. So it is the easier time to measure CVP. But sometimes when the patient has intrinsic PEEP, or if you applied external PEEP, the intrathoracic pressure at end expiration is not 0, it's higher than 0. So it could be difficult to know the transmural pressure. For example, a very short example, CVP of 12 at end expiration, PPi of 10 meters of mercury. And I can give you the airway pressure transmission of 60%. It is simple. The true CVP, is it 12, 10, 7, 6, 4, 3, 2, 1, 0? It is very simple. It is 12 minus the transmitted PPi. And the transmitted PPi is 10 times 60%. So the net result is 6 meters of mercury. It was not 12. It is 6. So in terms of fluid infusion, if you rely on CVP measurements, there is a high risk of under-resuscitation. But the problem is that I give you the airway pressure transmission 60%. But the patient, when the patient presents at the emergency department, he cannot give you the airway pressure transmission because it varies from patient to patient. So it could be very difficult in the real life to know what is the true transmural pressure you have to take into account for fluid infusion, for example. So there are many sources of measurements, and unfortunately, until now, maybe it will change, nothing is specified in the SSC guidelines, which assume that every ICU doctor or nurse is an expert in pressure measurements. So my conclusion is, should we still use CVP today? Yes, but in some conditions. No for the prediction of fluid responsiveness. Probably yes for helping to stop fluid infusion as a safety limit. Also probably for assessing RV dysfunction and its response to therapies, but in this case you need to use the transmural pressure. Also probably for assessing downstream pressure for organ perfusion, but you need to measure the intramural pressure and be aware of the multiple sources of error in measurements. Thank you very much.